Good afternoon. I'm Dr. Duke Majan, CEO and founder of Duke Spine Institute. We're broadcasting live spine surgery for your viewing pleasure and edification. Our patient has back pain. He's from Florida. And he's got 2 herniated discs. Can I start, Dr. B? We're going to go in and repair the 2 discs. One of them we're going to repair on both sides, and the other one just one side. So it's L4-5 bilateral repair, L5-S1 one side. Now, why are we doing a repair of the disc? The answer is the disc is the cause of this patient's symptoms. He has back pain, he has leg symptoms. It's all due to the herniation. And we're going to go in and repair these discs so that they no longer cause back pain or leg symptoms for him. That's our goal. Shot? All right, now to do that, we have to get into the discs. So we're going to start by getting into the L5-S1 disc on the left. Everyone agree?
Yes, sir.
Shot. To do that, I have to place a needle. The needle I'm placing is going to go all the way down to the disc. Shot. And then it's going to enter the disc in the back through a tear that's already there. How do I know he has a tear? Well, he's got a herniation. Shot. You can't have a herniation without a tear. So everybody with a disc herniation has a torn disc. All right, let's get an AP view. To navigate the needle, I have to use an X-ray machine. I have to look at the spine through the X-ray machine. So my needle is hitting the facet joint. Facet joint is enlarged at 4,551. Yep, that's okay. We're going to get around it. Shot. We just got around it. Shot. Can you give me another AP, Jordan? If you have questions, feel free to ask me. But first step of the surgery is get ourselves into the herniated discs using a needle. Shot. Shot. AP. I think we're off on orbit there a little bit. Are we? It's not much, is it? Interesting. What do you think, Jordan? I think we're off on orbit. Look at the pedicle of 4. It's off. Shot. I can't tell. What? Think that's worse? Yeah, go the other way. Sorry, folks, we're trying to align the X-ray machine properly with the patient's body. I think maybe you're right. So maybe there's some scoliosis at 4-5 that's throwing it off. All right, so here's what I'm going to do. I'm going to come. What do you think? You like that? That looks pretty good, huh? I agree with you. That might be all right then. Shot? Sorry, AP. Let's see. I may have to start a little bit more lateral. Quick shot. I think I might have to start more lateral. Shot. Shot. The reason I have to start more lateral is I have to get more medial at the end. I have to be more towards the disc. I'm too far away from the disc by the time I get to the back of the disc. I know it's hard to make sense of what I just said, but that is the God's honest truth. All right. Shot. Still got to get around this facet. Shot. Give me an AP. Henry, let's show the audience while I'm placing these needles, what are the most common causes of chronic back pain? I'm Dr. R. Deukmejian with the Duke Spine Institute, and we're going to discuss 30 causes of chronic back pain. Chronic back pain is back pain that lasts longer than 6 weeks, and there are 30 causes of chronic back pain. The most common cause is going to be a disc injury. Disc injuries such as disc herniations, disc bulges, disc ruptures, degenerative disc disease account for 86% of chronic debilitating back pain, and they are totally fixable with the proper treatment. The best treatment for disc injuries is Duke laser disc repair. Let's take a look at the 5 lumbar discs that can be injured. The most common disc to be injured is L4-5, followed by L5-S1, then L3-4. The L1-2 and L2-3 discs are far less commonly affected. Next, we have facet joints. Facet joints are small joints located behind the discs in the back of the spine. There are 10 facet joints, each paired left and right, L1-2, L2-3, L3-4, L4-5, and L5-S1. The most common facet joints to cause chronic back pain are L4-5, followed by L5-S1, followed by L3-4, in that order. After the facet joints, which account for approximately 10% of chronic back pain, we move on to the sacroiliac joint. The sacroiliac joint accounts with the piriformis muscle for approximately 4% of chronic back pain. The sacroiliac joint is a joint located between the tailbone or sacrum and the iliac bone. There is a left and right sacroiliac joint. In this diagram, you can see the joints turning red, indicating inflammation and pain either in the left or right sacroiliac joint. These sacroiliac joint injuries and pain can be treated most effectively with the Duke plasma rhizotomy of the SI joints offered at Duke Spine or Duke Joint Institute. The 4th most common cause of chronic back pain is a piriformis muscle injury. The piriformis muscle is located in the buttock, and there is a left and a right piriformis muscle. The muscle gets torn, unfortunately, when people bend the wrong way. This usually occurs in patients with orthopedic problems such as hip pain, knee pain, or back pain. By bending improperly, they put the muscle under too much stress and they tear the muscle. The torn piriformis muscle causes severe debilitating pain in the top of the buttock. There is a left and a right piriformis muscle, and this can be treated most effectively with the Duke piriformis muscle release. This is performed percutaneously with a 4mm incision. The sciatic nerve does run through the piriformis muscle, and many patients with piriformis muscle syndrome also have sciatic pain down their legs, with pain, numbness, tingling, and weakness in the leg that's affected on the side of the piriformis muscle. Piriformis muscle can be treated with injections such as steroids, Botox, PRP, or stem cells. However, those injections always wear off and the patients end up coming back with the piriformis muscle pain that reoccurs. The most definitive treatment for permanent relief of piriformis syndrome is a piriformis muscle release. Next, injuries to the bones of the spine, such as the vertebral bodies, with trauma can cause fractures of the vertebral body. Vertebral body fracture is diagnosed with X-rays or CAT scan or MRI, and they're treated with injection of cement into the vertebral body. Looking at the vertebral bodies, the most common to be affected is L1, followed by L2, then L3, L4, and L5. The sacrum can also be fractured. Finally, the coccyx is the last cause of chronic back pain. You can see in the diagram the red coccyx at the bottom. This comes usually from an injury where the patient falls on their bottom, sustains pain at the tailbone, and this can be treated with injections of the coccyx ligament. These are the 30 most common causes of chronic debilitating back pain, the most common being the disc, causing 85% of chronic back pain, followed by the facet joint, causing 10% of the chronic back pain, followed by the piriformis muscle and sacroiliac joint, which cause 4% of chronic back pain, totaling 99% of chronic back pain, which is totally fixable and curable with the right treatment. Thank you. I'm Dr. Deukmejian. Thanks for joining us. Shot, welcome back. We were just placing, we were just able to get into L5-S1. It was very difficult, but we finally made it. Sean? The reason it was difficult is because the facet joint was pushing my needle laterally away from the disc. And if you can't get past that facet, then you're not able to do the surgery. AP? All right, lateral. Shot. 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 All right, what are we showing the audience?
As of now, we are showing the fluoro.
Shot.
And yeah, we're showing them that. And we do have a question.
Sure.
Coming from Frank on YouTube.
Shot. Sure, Frank. Happy to take it. AP?
Saying, Dr. Duke, how are you? Today was a busy day for you in the OR. I just finished watching your first surgery, the one where you had a problem with your suction.
Was that the first one? That wasn't the first one.
That was the second one.
That was our second or third one. But yeah, I think you're right. It might have been the second. I'm okay now. But yeah, that was stressful. Obviously, the patient was shot. The patient was basically asleep, right? All right. The patient was a challenging case because he was big and we had 6 levels to do. Normally we don't do 6 levels, so I was really pushing the limit. But you know, he's a big guy and he was starting to have trouble breathing. We had to stop the surgery, so it was a bit frustrating for me that I couldn't get more done to help him get more done because the suction wasn't set up properly. So we rectified the situation and now we should be fine. That's code for the nurse no longer works here. Look. The hardest job in this operating room is either the anesthesiologist's job or my job. And there's really no excuse for the other people to not do what they're doing properly. If I can do my job well and the anesthesiologist does his job well, then everybody else should be able to do their job well too. That's kind of what I expect. And in the end, when we don't do what we do well, the patient suffers. It's not about me suffering, it's about the patient suffering. And I don't want my patients suffering. I want them to come here, have a great experience, have a great surgery, and leave fixed. That's my goal for every single patient. So when something gets in the way of that, it really bothers me, okay? That said, we got a great team. I just think we had a situation that could have been avoided, but in the end, it's going to be fixed at this point. All right, we are in L5-S1. This patient had 2 bad discs. One of them was bad on both sides, right and left. That's the L4-5. The L5-S1 is only bad on the left, and we're going to go fix it for him. When I did the discogram at 5-1 just a few minutes ago, he actually responded with some pain. So I feel really good that we're fixing the right place, the right pain source in his body. Any questions, feel free to type it up. But yes, I'm a bit tired. It's been a long week for all of us. My entire team is tired. Everybody's been working so hard, and we've done a great job this week. We had like 10 surgeries with me, and then Dr. Patel had a bunch of surgeries too on Monday and Wednesday. So it's been a very, very busy week, and they're going to get some rest next week. We all deserve a little bit of rest. All right, let's get the endoscopic view, please, on the monitor. Yep, there it is. We are, oh, that's beautiful, guys. Look at the red and pink tissue. That's the inflammatory tissue. It's like a giant zit. You know, zits are red for a reason. There's a lot of circulation in them. That's why they turn pinkish red, and they're super tender. That's exactly what's causing his pain right there. So I'm going to zap it away with a laser, and that pain will go away. I'm very happy about that. Henry, let's show the audience once again with our animation, why do disc herniations cause so much back pain and neck pain? What is it about them?
Disc injuries start with an annular tear, damaged nucleus. Pulposis herniates into the annular tear. The herniation triggers an inflammatory response within the annular tear. The inflamed annular tear generates pain signals. For more details, please visit our website or call us at 1-800-FIX-MY-BACK 349-6922.
All right, we have a question from the audience. We'll take the question, and then after that, we're going to show you guys how we fix the pain from the herniation with the laser.
Coming from Frank once more on YouTube asking, Dr. Duke, why do you use staples to close up at the end instead of steri strips?
You know, Frank, it's a great question. So the answer is we could use steri strips, but here's what's going to happen. At around 11 o'clock tonight, the patient's wife or husband will say, "Oh my God, you're bleeding." Because with steri strips, you're going to ooze some blood. So they're going to say, "Oh my God, you're bleeding. Honey, what should we do?" "I don't know. Don't we have Dr. Duke Majan's phone number?" "Yes, but it's 11 o'clock at night or 1 o'clock in the morning. Should we call him?" "I don't know. Let's wait another hour and see what happens." And then an hour later, it's 3 o'clock in the morning. "Oh my God, there's still some oozing of blood. We should call him." And then I get that phone call, and they say, "The incision's oozing. What should we do?" And I say, "Don't worry about it. It's normal. Have a good night." So basically, to summarize, the patient gets very nervous about the little bit of bleeding. The wife or husband gets very nervous. Everybody gets nervous. Everyone's freaking out, and they're panicking. In the end, it's absolutely not a big deal. But better than that, we just put a staple. It doesn't allow that oozing to happen. And the patient comes in the morning for a checkup. We get rid of the staple. So it's really more just treating the patient properly by avoiding the oozing that's going to happen the first night and avoiding all that consternation and concern that they're going to have. And nothing more than that. We could use a steri strip, but the steri strips 100%, they're going to ooze. The blood will get under the steri strip. It'll pull it off the skin, and then we're going to have to redo the steri strips in the morning. So rather than do that, we just do the staple. But I think steri strips are a perfectly fine option. We've tried glue in the past. The problem with glue is that, once again, with all the oozing that's going to happen in some patients, you're going to have the glue just separate from the skin, and you're going to have to do something else the next day. So the best is just to use a few staples and just take them out in the morning. We've tried everything else. That's the best way to do it.
Apart from that, no current questions.
All right, good. I will tell you this patient wrestles alligators. He's an alligator wrestler. That's not his main occupation, but he's been known to wrestle a few alligators down. Right? No. I know the feeling. Actually, my daughter and I were walking on the street the other day, and we found a baby gator, and we actually did a photo shoot with it before we put it back in the swamp.
You got it?
Yeah.
Oh, wow.
Oh, yeah. Are you kidding me? I used to be a big reptile collector for years. I've had snakes, lots of lizards. My biggest lizard was a monitor lizard. I think it was a Sumatran water dragon or something, an Indonesian water dragon. Second largest land lizard in the world. He actually was 6 feet. And what happened was my best friend, Chris Kapashkin, is a neurosurgeon, trained several years ahead of me, became good friends. Both of us loved reptiles. He was diagnosed with cancer, and his dream was to have one of these giant lizards. So he knew he was going to die in about a year. So he asked me, if I buy this lizard and I die, will you take care of it for me? And I said, of course, I'll take care of it. So he bought the lizard, and when he died, I literally got a FedEx box in the mail, just one of those boxes that you see. No, to Ara Duke Majin with my address. This was when I was a resident in neurosurgery in Gainesville. And there was no message, no note. I just opened the box and emptied it upside down on the table, and a lizard came out. A lizard. Right on the table. And I looked at who sent it, and it said Lisa Gapashkin, his wife. She never called me or told me it was coming. She just shipped it. And I think she wasn't happy with me because I told her husband that I would take care of the lizard, so he bought it. And then she had to get rid of it, obviously, when he died. But she was going through a lot, so I didn't hold that against her. And I built the lizard an enclosure in my garage that was made out of plexiglass and wood, a wood frame. I kept the lizard in there. His name was Salvador. I named him Salvador for salvation, because he was the salvation of my friend, Chris Kapashkin. Anyway, Sal grew up, got really big. He went from 12 inches when I got him to 6 feet in about 3 years. And I fed him well. My wife and I took good care of him. Took him out for walks. He had very long nails. I bought a leather jacket just so I could hold him, because otherwise the nails would dig into your flesh and rip your flesh off. It was unbelievable how powerful that animal was. But he was very peaceful, very calm, never bit me, never scratched me intentionally. And when we moved to Brevard, we kept him outside in a giant dog pen with a dog house and a heating pad and a heating light. I fed him eggs and rats, and he was the happiest lizard around. Until one day when my gardeners unplugged his electricity without me knowing about it. I wasn't home, I was out on vacation. And when I came home and he was frozen to death, this was during the winter time, and it went down into the 40s. And he's not meant to survive in the 40s. Of course, it broke my heart, but at least he didn't suffer. He went out quickly, had a good life. But that's my story of Salvador, or Sal as we call them. That was, I think my son had just been born. My daughter was on her way. when all this took place with Sal. Anyway, that said, I've had many, many, many snakes and lizards in my lifetime. A notable snake I had was an emerald green tree boa. Beautiful animal. Never bit me once. I had an anaconda, specifically a green anaconda. There's two types of anacondas, for those of you who don't know. There's yellow and green. Anaconda, of course, is the largest snake in the world. I got a baby and I brought it up. Brazilian rainbow boa. Mostly boas. I didn't have any pythons. That was back in my college and medical school days. Great pets, by the way. Snakes. They're quiet, they're clean, they eat once a week usually, and they're very easy to care for. All right, just about done with this disc. This is going very well for the patient. I think he's gonna do exceptionally well here. Any questions?
No current questions, but we do have a comment coming from Frank once more on YouTube.
Yeah.
Saying, Dr. Duke, there was an episode on Leave It to Beaver where Beaver and Wally ordered a baby alligator and it came in the mail in a shoebox.
Huh. That's pretty much what happened to me. Except there was a Sumatran monitor instead of an alligator. That's funny. Thanks for sharing, by the way. Brings back a lot of memories. A lot of memories. First snake I ever had was something called a ringneck snake. As a matter of fact, you can find ringnecks in most places that are warm. They don't get much bigger than about 6 or 8 inches. They're tiny and easy to care for. I had to dig up worms and feed that snake. Pretty much every couple of days is what I did. I graduated from that guy to a boa constrictor, which was my first kind of big snake. Great pets though when you're in college because they are so easy to take care of. Funny story, we're done. I actually bought the boa constrictor. So I went to UC San Diego, lived in the dorms, and they tell you you're not allowed to have any pets when you're living in the dorms. None, like zero. No fish, no, nothing. So I started school, and every group of dorms has what's called a resident advisor, or RA. And they're basically an upper class person whose job is to make sure that you're following all the rules, staying out of trouble, not having parties, you don't have any pets in your room. So my RA's name was Jason. And one day he came over and said, yeah, you should come over to my place. So I went over to Jason's room, opened the door. First thing that was there on the floor was a giant turtle. And then there were rats crawling around everywhere. He had a dog, a cat, rats, snakes, lizards, an iguana, fish. I mean, he had more pets in his room than I've seen at the zoo. And he was the resident advisor who was supposed to make sure we all followed the rules.
So he was,
Funny.
how you call it?
Huh?
He get it from other people and he keep them?
No, he just loved animals. And anyway, so he had a snake that had babies, a boa constrictor. And he said, you want to buy one of my snake's babies? I'm like, but I thought we're not allowed to have animals. And he said, that's okay. Just don't tell anybody. Aren't you the RA? Anyway, I paid $100 for the snake, and that was my first big snake. A Colombian red-tailed boa, it's called. Colombian red-tailed boa. Beautiful animal. Had it for many, many years. Colombian red-tailed boa. Anybody else here have snakes?
I had one once.
Yeah?
It wasn't for me.
I'm not talking about your high school boyfriend. I mean snakes. Like reptiles.
A little yellow, like, is it tree python or something?
A yellow tree python?
Something. It was little. It was
Hold on.
big.
Let me see. What you got there, Jordan? Let's see what you got. Let me think. How big was it? Yeah.
He was little, but he was mean. I didn't know what to do with him.
Mean as in he bit you?
Like he would hit the glass.
Really?
Yeah, like headbutt it.
Yeah. Those are the kind of snakes you don't want.
Nope, I sold him.
Yeah. You can always, snakes have different temperaments. Some of them are very, very sweet. They will never bite you. Other ones are really mean. And I made sure I never bought a mean snake.
After that, I was done with snakes.
But the anaconda was kind of like that.
I've
It,
seen that movie.
it was a biter. You know, that's why the movies are just ridiculous. Because I've had these animals. I know how they think, how they move. And those movies are ridiculous. They don't move that way. They don't. Huh?
Do they really get that big?
Anacondas?
Yeah.
They get 25, 30 feet. Yeah. Probably some bigger than that. Not anacondas. You find pythons in the Everglades. Anacondas are very, very hard to find. They're very rare. At least in the United States, you don't see them. All right, we moved on to the left L4-5. Any questions?
No current questions, but we do have a few comments. This first one is coming from Sunil on Facebook,
Hello, Sunil. It's good to hear from you again.
saying that they had surgery here with you, Dr. Duke, and no back pain after surgery. I am doing great and living a normal life. Great, Dr. Duke. Thank you.
God bless you, Sunil. Yeah, I remember Sunil very well. Sunil, you're the second patient that came today to our surgery and told us about your experience and shared it with the world. So thank you for doing that. Thank you so much. It means a lot. It's good for people to hear from our patients. It's good for me to hear from our patients. It's good for my team to hear. All right, why are we not getting to 12 o'clock with this fiber? I don't understand what's happening here. It's weird. Right? Like normally we can get it up to 12 o'clock. That's better, I think, yeah. All right. Thanks, Sunil. Great to hear from you. Who else do we have comments from?
We have a comment coming from Sherry on Facebook
Hello, Sherry. Welcome to our live stream.
saying, I will stick with my horses.
Ah, of course. Yeah, horses are the most beautiful animals. I love horses. I just wish I had a place to ride a horse here, you know? And by ride a horse, I mean like a nice place, you know? Like there's always a place you can ride. You can ride them on the street, but I like horseback riding like through a forest, you know, where it's just peaceful and quiet and beautiful. Love horses. I'm glad you have horses to enjoy. My daughter likes horses, Ariana, right? Who's been horseback riding here? Anybody in this room?
I have.
Henry, you have?
Yep.
Where did you go horseback riding?
I did one in upstate New York. There was an area near like northern Florida that I did that, and then I think Virginia one time.
Wow.
So yeah, a few times.
So you really have done quite a bit. What's your favorite place you went horseback riding?
Oh, definitely upstate New York. That was beautiful. You could see like the outskirts of Albany while you were up on the mountain, mountaintops, and you're with a group of. It was camp, so like you were with your campers, your counselors, and all that, and that was just the best. And my horse, I forgot his name, but he was such a fun guy to hang out with.
Nice.
So yeah, it was really, really awesome.
It's weird. Sometimes you remember your horses' names. I have one in Mexico. I never forget the name. Muñeca, which I don't know what it means. Muñeca. Huh?
Muñeca is like a female version of a doll.
A doll? A dog?
Doll, like a
Doll.
Yes.
Ah, female doll.
Yes.
Luis said Muñeca means female doll. So yeah, my horse was Muñeca. She was one of my favorites. My favorite place I rode was in Wyoming.
Oh wow.
Yeah. Rivers, forests. It was unbelievable.
Yeah. Riverside with horses, I'm sure, is like the best. I didn't have that opportunity, but I forest and water rivers. I see why.
If you guys ever get a chance to ride horses, I strongly recommend it. Just go with an outfit that does it all the time. So they got to match the horse to your body and kind of your personality. I've been thrown from a horse. Yeah, you have?
Yes.
When did you get thrown?
Long time in high school.
Yeah, a long time ago, right? Me
I
too.
thought the horse is gonna like a jump a fence, and he stopped. So I went.
You kept going.
Yes. Yeah.
Yeah. I was crossing a river and my horse reared and I wasn't expecting it. And of course, I just fell right off the back. Thank you. Well, it was on rocks, on the river rocks. Yeah, that's fine. That was the only time I've ever been thrown. I did have a horse go down once, like we were in Wyoming, and the horse went down on their knee because we were going down the hill. I was pretty heavy back then. I was like 280 pounds, so I felt bad for the horse. I was really overweight. Ariana, do you remember that?
Yeah. I felt bad for your horse too.
Oh, thanks. What can I do?
Well, you lost the weight, so.
I lost some weight now, yeah. That's better. Who else has been on a horse? Berndes, you ever ride a horse?
Yeah.
That's my dream, is to have a house someday out in the, like Colorado or something, you know, and just be able to get on a horse and ride.
Sherry commented, "Take a ride in the Rockies. It's flipping awesome."
Right, Rockies, that would be cool. Yeah. I would love to do a trip like that. You know, Rockies or the Appalachian Trail would be probably pretty cool with a horse,
Yeah. Oh my goodness.
right?
That's one of my favorite places is the Appalachians. I love them, so I encourage that. That would be awesome. I know Frank commented, "I used to go horseback riding in Scottsdale, Arizona.
Oh, wow.
Out in the desert when I was a kid. We used to vacation there a lot."
Man, that's beautiful. I love Scottsdale. That's a gorgeous area.
It is. My grandmother used to live there.
Uh-huh. I mean, every time I've been there, though, the weather's been so nice, but I've heard that it can get so hot. What? Yeah, it can get hot. I just think it's so neat, that scenery out there, you know, there's rocks and the landscape is so beautiful and the sky at night. It's gorgeous. Is that what it is, a Sonoran Desert? Yeah. Well. Ariana, I took you to Scottsdale when you were just a baby. Just a little tyke. All right. What do we need to talk about, Henry, at this point? Any questions from the audience?
No current questions, but we do have a comment coming from Frank once more on YouTube.
Sure.
Saying, "Dr. Duke, tomorrow I'm doing my MRI on my neck. I'm getting it done at Simon Imaging. The self-pay price is only $200 Soon as I get my disc tomorrow, I'll upload it to you.
That's a great price, my friend. $200. That's even better than what we offer. We offer, I think, $300. But that's good pricing. You got a good deal.
Apart from that, no current questions or comments.
All right, so we've shown the audience how the disc injury causes back pain and leg pain. Do we show them how we fix it with laser?
We have not. We have not shown them that.
Let's do that.
Of course.
Disc injuries are a common cause of chronic back pain. The inflamed annular tear causes back pain. A 1/4-inch sized skin incision is made. A small tube is inserted with no damage to the bones or soft tissues. The laser removes the herniation and debrides the annular tear. The annular tear heals on its own after the procedure, which can take up to 12 months. For more details, please visit our website or call us at 1-800-FIX-MY-BACK 349-6922.
All right, welcome back. We have just completed what you watched there on the animation, which is a laser debridement of the annular tear. We did that right here at L4-5. We're going to go to the right side now and do the other side at L4-5. His L4-5 was really bad. It was sticking out pretty far, and I'm going to take out as much as I can. I think he's going to be very happy with the results. Of course, for those of you who don't know, when a surgeon goes in and works on a herniated disc, you're never going to get 100% of the herniation. It's impossible. There is no surgeon in the world that can do that. The only way is to basically, I don't even want to talk about it, but basically the patient would not be alive at the end of the surgery. That's because there's structures, very important structures around the spine, around the disc, that block the surgeon from getting 100% of the herniation out, like blood vessels that you can't injure or sacrifice and move. There's veins, nerves, bones, ligaments, and all these structures are important. You can't get rid of them. So what we'd have to do is work around them, work between them, and that's what we're doing with this endoscope. The nice thing about the endoscope is we're using the smallest path possible to get to the herniation and work on it. Shot. But even though we use this really minimally invasive path, it's still not able to get 100% of that herniation. We get the very best view of it, but it's not going to get 100%. So we get as much as we can. And that typically is around 60%. Now, the good news is you only need to get about 50% to get rid of the patient's symptoms. You don't need more than that. So 50% usually does the trick. So I always aim for 50% or more. The good news is this particular exposure, path, trajectory, technique that we use pretty much guarantees we're going to get 50%. And usually we can get 60, 70%. All right. We're inside the disc. You see the inflammatory tissue once again, it's pink. That's what we want to work on with the laser. Just the laser. Any questions?
At this moment, no current questions.
The other point I'd like to make is that the herniations are never just one piece. They're always many pieces, kind of like a bag of marbles that are putting pressure on the nerves or causing the inflammation. It's like a bunch of pieces. It's never just one. Grab her. I don't know, this seems to be doing better, this laser now. Maybe it's just the disc. I think this disc is just better. How is our last patient, guys? All right. All right. Thank you. We're just about done. We'll be done in 10 minutes. 10 minutes, Dr. Burndas. That's a piece of herniation, by the way, right there. So the laser will free up the pieces because they're usually stuck down to the annulus, which is the wall of the disc, and they're stuck because of scar tissue, and they get scar tissue because of inflammation. It's the inflammation that causes the scar tissue that causes the herniations to stick to the wall, and that's what causes the back pain, is all that inflammation. Any questions?
At this moment, no current questions.
So we've covered 30 causes of back pain.
Correct. What causes
We've covered
Yep.
discogenic back pain. How about we show the audience the piriformis syndrome?
Yeah.
And by the way, Henry and I have just completed with our animator the hip DPR video, which Henry is going to be uploading probably tomorrow or this weekend.
Yes. Tomorrow, this weekend, worst case. But we're very excited, and we just got the link for it, so it's awesome.
So you'll get Tom Bean to add the Band-Aid, and then you'll do the voiceover?
Yep. Emailed him not that long ago, and yep. Once we get that, we're gonna get the voiceover and the music going, and then have it uploaded.
And then you guys can all watch how we treat arthritis of the hip pain with our new technology, the Duke plasma rhizotomy, without basically opening the patient up at all. I just saw a patient in clinic last week who had the Duke plasma rhizotomy for hip pain in both of her hips. She said that her hip pain was 100% gone in both hips. Now, it doesn't work in everybody. We have probably about 15% of the patients that still have pain afterwards. Look at that inflammation tissue right there. You guys see it?
Yes, we do.
It's really pink right there. That's where the pain is coming from. But as you get closer, it kind of washes out, right? Because it's too bright. But when you get further away, you can see how pink it is. Huh? Right there. That's where the pain comes from. So we just killed the pain right there by removing that inflammatory tissue. I'd say 7 minutes left.
In the meantime, why don't we show the audience of how it is that we cure piriformis muscle pain?
I like it. Do it.
A piriformis muscle tear can cause lower back pain and sciatica. A piriformis muscle injury causes a tear, in which piriformis muscle inflammation causes back pain. And also, piriformis muscle inflammation may cause sciatic pain. The best treatment for piriformis muscle syndrome is the Duke piriformis release. From there, the piriformis pain is permanently eliminated. The advantages with the Duke piriformis release is that it's an outpatient procedure, which would take up to about 30 minutes. Minimal bleeding and pain after the procedure with an immediate recovery and return to work the next day, as well as a 99% success rate with permanent pain relief with a single treatment. For more details, please visit our website at www.dukespine.com or call us at 1-800-FIX-MY-BACK, 349-6922.
All right, welcome back. So there it is, piriformis muscle syndrome. Probably the second or third most common cause of back pain. Before we used to just treat it with shots, physical therapy, but those things don't work. The pain keeps coming back. So we started to do the release, and that cured the pain permanently. I got 3 minutes left. Berndes? So you can see in the video that once you get a tear in the muscle, very hard to get rid of that tear. We just keep re-injuring the muscle, and it keeps flaring up the pain. The pain in the buttock from the tear can actually travel along the sciatic nerve, very common, because the sciatic nerve is right there in the muscle. And when the muscle is inflamed and swollen and painful, that inflammation gets on the sciatic nerve. Thanks. So it's actually the piriformis is actually the second most common cause of sciatic symptoms. People with piriformis have a sharp stabbing pain in their buttock. I actually did a MRI review with a patient who had piriformis syndrome, and his wife works for a neurosurgeon that does piriformis muscle release, but he does open release, and the patients typically do very badly as a result of the open release. It's very painful, bloody, disfiguring, and there's a high risk of complications, but not with the Duke laser not with the Duke piriformis release. Ours is minimally invasive. All right, I'm pulling out the last few pieces of herniation here from the tear. You got it? Once I get these out, we'll be done. They're stuck down pretty good. There's a good size one right there. It just keeps breaking apart. Trying to pull it out, but it's pretty big and it's pretty stuck down. You guys see it?
Yes, we do.
It's too big to fit in the tube. Hold on, rock the tube this way. This is the last piece of herniation, but it's big. I'm gonna have to break it into parts. Just take it out a little bit at a time. This is our last piece of herniation, but it's a huge one there. It just keeps like flaking apart. It just doesn't want to come out. No. Just about done. We've cleaned out most of the tear. I'm just taking out the last few pieces of this big herniation. I think we got it, finally. Got a little bit there with the laser, and then we're done. Any questions?
At this moment, no current questions.
All right, everybody. Thanks for joining us this week. It's been a long week, and we've just finished our final case for the week. We'll be back in 2 weeks. Next week we're out. So please join us for some more live spine surgery. July 7th week. We'll be back for more interesting live streams, taking your questions. We're also going to have our first podcast released by then, so you can watch the podcast on Spotify.
100%.
Sitting on me. Thank you. Scope off, please. Thank you.
All right, Henry, we done?
We are done.
All right, buddy. Thank you. Great job today.
Of course, you all of you as well.
Let me see that video when you're done with it. The hip animation. Send it to me, okay?
Copy that. You got it.
I got it. And then, of course, when you're done with the podcast intro and first episode, I would love to see those as well.
Oh, you got it. Not a problem. I'll send the trailer tomorrow for sure.